Hi everyone, it's Dr. Nikki. Welcome to my lecture on Lexapro, which is the brand name for Escitalopram. This presentation is going to cover what Lexapro is, what it is approved for, how it works in the brain, what the research says about nutrient status with this medication, the warnings that are rarely discussed with patients, drug and herb interactions, and some supportive strategies will also be discussed. This is not an anti-medication lecture. I want to be really clear about that. Lexapro helps a lot of people. This is about informed use because understanding what is happening in the body alongside of medication makes everything work better. So let's start with the basics. What is Lexapro? Lexapro is the brand name for escitalopram oxalate. It belongs to a class of medications called selective serotonin reuptake inhibitors, or SSRIs. The FDA approved it in 2002. It comes as a tablet in 5 milligram, 10 milligram, and 20 milligram doses, and it is also available as an oral solution. It is taken once daily, morning or evening, and can be taken with or without food. Now, what is actually FDA approved to treat? Two conditions. It's first approved for major depressive disorder in adults and in adolescents aged 12 to 17. Second is generalized anxiety disorder, but only in adults. It is important to note that it is not approved for children under 12 for depression, and it is not approved for anxiety in anyone under 18. That is a boundary that matters clinically, especially for those of you working with pediatric or adolescent patients. The standard dose is 10 milligram once daily. The maximum is 20 milligram. What is interesting is that research did not demonstrate additional benefit at the higher dose for most people. So going to the 20 milligram is not automatically better, it just means more medication. So how does it actually work? Let me break this down simply. Serotonin is a brain chemical that helps regulate mood, sleep, and emotional response. In a healthy system, serotonin gets released into the space between two nerve cells, does its job, and then it gets pulled back into the cell that released it. That process is called reuptake. Lexapro blocks that reuptake process, so serotonin stays in the space between the nerve cells longer, which increases serotonin activity in the brain. Now, here is something that surprises most people. The medication starts affecting serotonin almost immediately on day 1, but mood improvement typically takes 1 to 4 weeks. So why the delay? And that's because the immediate rise in serotonin is not the whole story. The brain has to adapt to that change over time. Feedback systems desensitize, serotogenic signaling gets retuned, and neuroplasticity related changes accumulate. Research using brain imaging has found that these plasticity signals evolved over 3 to 5 weeks with Lexapro specifically. Some early symptom improvement can appear in the first week, so the old thinking that SSRIs do nothing for a full month is too rigid. But full benefit requires the brain to reorganize around the change. And here is the part most patients are never told. Lexapro works on the serotonin that is already there. But your brain needs specific nutrients to make serotonin in the first place. If those nutrients are low, the medication has less to work with. That is what this next section is going to be all about. This is part of the conversation that almost never happens in a standard prescribing visit. And honestly, it is the most important part of this lecture. So you're now looking at the folate-serotonin pathway diagram. Let me walk you through it from top to bottom. Your brain needs a specific form of folate called L-methylfolate to produce serotonin. You get folate from food, things like leafy greens, legumes, and fortified foods. But before your brain can use it, it has to be converted into L-methylfolate by an enzyme called MTHFR. And here's the important part about that. L-methylfolate is the only form of folate that can cross the blood-brain barrier. Once it gets into the brain, it helps produce a molecule called BH4, which activates the enzyme that starts serotonin production. So having no L-methylfolate means reduced BH4, which means less serotonin being made. And then Lexapro works at the bottom of this pathway. It tries to optimize the serotonin the brain already has, but if the supply chain above it is compromised, the medication is working with less than it needs. And that is the paradox. You're on an antidepressant that targets serotonin, but the nutrient your body needs to make serotonin in the first place may not be getting to the brain efficiently. And this is where it gets especially relevant for my audience. Neurodivergent individuals and women with PMDD have higher rates of MTHFR variants, and that impairs the conversion step. So this does not mean everyone with MTHFR will have a poor response to Lexapro, but it does mean folate status is worth checking and knowing. And I want to be transparent about the research here. Most of the studies in this area use fluoxetine or Prozac, not Lexapro specifically. Research on individual SSRIs are pretty limited, especially SSRIs and folate. But the folate BH4 serotonin mechanism operates upstream of where all SSRIs work. So the finding applies to the drug class, and we use the class level evidence to inform our thinking. A 2000 randomized placebo-controlled trial found that women on Prozac plus folic acid had a 93.9% response rate compared to 61.1% in the group taking Prozac alone. Same medication, same dose, the only variable was folate. A separate study found that patients with low folate were significantly less to respond to antidepressant treatment overall. And more recent clinical trials found that adding L-methylfolate to an ongoing SSRI in non-responders doubled the response rate compared to a placebo augmentation. That's pretty huge. And here are some slides to represent that. All right. And so let's talk about the FDA warnings that nobody really discusses. Lexapro prescribing information contains warnings that most patients are never walked through at the time of prescribing. I want to go through these because they are clinically significant and they deserve a conversation. So the first is a black box warning on suicidality. Lexapro and other antidepressants carry a black box warning for increased risk of suicidal thinking in children, adolescents, and young adults under 24, especially in the first weeks of treatment or when the dose is changed. Patients and their families need to be told to watch for new or worsening mood changes, agitation, or unusual behavior and report it immediately. The second here is serotonin syndrome. Serotonin syndrome is a potentially life-threatening reaction that happens when too much serotonin builds up in the body. It is most likely when Lexapro is combined with other serotogenic medications or certain supplements. Symptoms include agitation, rapid heart rate, high blood pressure, sweating, muscle twitching, and in severe cases, confusion and even loss of coordination. St. John's wort is specifically named in the FDA label as a risk, and I'll come back to that. So third is discontinuation syndrome. Stopping Lexapro suddenly can cause electric shock-like sensations, dizziness, mood swings, irritability, nausea, and anxiety. These are not signs of addiction, they are the nervous system adjusting to a rapid change. Because escitalopram has a shorter shelf life than some other SSRIs, stopping abruptly is more likely to cause noticeable withdrawal symptoms. A gradual taper off Lexapro is always recommended. So fourth is hyponatremia, which is low sodium. This one is particularly important for my audience. SSRIs carry the highest risk of low sodium among all antidepressants. And Lexapro was specifically named as a higher risk agent in research examining sodium levels in antidepressants. Women, older adults, and those on diuretics are at a greater risk. And symptoms of this include headache, difficulty concentrating, memory changes, and confusion. Sodium monitoring in early treatment is pretty clinically reasonable. Fifth is an increased bleeding risk. Lexapro affects how platelets function, and the risk compounds when it is combined with NSAIDs like ibuprofen, aspirin, or blood thinners. And this is actually directly on the FDA label. And sixth, I want to talk about activation syndrome in youth. In children and adolescents, SSRIs can cause a cluster of symptoms called activation syndrome: increased restlessness, irritability, impulsivity, insomnia, and anxiety. So they are frequently missed or misattributed to worsening of their original condition. This is one of the reasons careful monitoring is so important when starting or increasing dose in younger patients. So common adverse reactions, and this is showing columns here with the FDA label and then what actually I found when I was digging through the research. The FDA lists the following as the most common adverse reactions, meaning they occurred in 5% or more of patients at twice the rate in placebo groups. Insomnia, nausea, fatigue, and somnolence, increased sweating, decreased libido, ejaculation disorder, and agorasmia. What I want to point out is that sexual side effects, decreased libido, and difficulty with orgasm are almost certainly underreported. Patients and providers are often reluctant to discuss them, which means the actual incidence is likely higher than what appears in the clinical trial data or research we take a look at. These side effects are also a significant reason people stop taking the medication. The research literature shows the picture is broader than the actual list that we're taking a look at. So a 2021 narrative review identified 86 case reports connecting SSRIs, including Lexapro, to extrapyramidal symptoms, which are movement-related side effects, including restlessness, stiffness, and involuntary movements. Most of those occurred within 30 days of starting or increasing the dose. Additional effects documented in the literature included QT prolongation, skin reactions, weight and body composition changes, and also a possible association with cataracts with long-term use. Yeah. Nutrient status and SSRI users. So we'll take a look at what the data shows. A 2018 study using NHANES data, which is a large national nutrition and health survey in the United States, took a look at 655 adults who had been prescribed an SSRI for at least 180 days, compared them to over 12,000 non-users. So this is what they found. SSRI use was associated with a measurable reduction in bone mineral density. Over half of SSRI users had inadequate daily intake of calcium, vitamin D, and potassium. Inadequate vitamin D was associated with lower bone density in both SSRI users and non-users. So vitamin D is associated with bone mineral density. And the combination of SSRI use plus inadequate zinc intake was specifically associated with bone density, with low bone density. So SSRI use plus low zinc intake specifically associated with low bone density. So it's not something you think about often. I want to be clear about what this research does and does not say. It does not prove that Lexapro directly depletes these nutrients. What it shows is that people taking SSRIs in the population are commonly low in key nutrients and that those deficiencies have measurable health consequences. The authors of the study specifically recommended nutritional counseling and micronutrient monitoring for patients prescribed SSRIs. So this is not about adding more supplements. It is about knowing what the baseline looks like so we can make those informed decisions on what we should and shouldn't be adding into our diet or supplement regimens. All right, so let's take a look at drug and nutrient interactions with escitalopram. So this is important because escitalopram is metabolized by CYP3A4 and CYP2C19 liver enzymes and is a weak inhibitor of CYP2D6. That means several substances that can change how Lexapro stays in the body. There's a pretty long list. So cannabis, both THC and CBD are first on the list. This one surprises a lot of people, actually. Research has shown that co-administration of Lexapro with THC or CBD significantly increased the half-life and concentration of Lexapro in the body by inhibiting cytochrome enzyme activity. So in plain terms, cannabis can cause a medication to stay in the system longer and at higher levels than intended. This is Lexapro specific and not just a general SSR claim. Next up, ashwagandha. So combining Lexapro with ashwagandha has been reported in the literature to cause myalgia, epigastric pain, nausea, vomiting, restless leg syndrome, and severe cough. Ashwagandha is very popular right now, right? A lot of people are taking it. It's in the women's wellness space, a lot of conversation worth having with your patients or your provider if you're a patient on Lexapro or SSRI taking ashwagandha. Rhodiola rosea, I love this herb. So interactions between Lexapro and rhodiola have been reported, including cough, ejaculation disorders, bleeding, and ventricular arrhythmia. So again, this is another aptogen that is widely used for stress and energy. I like to use it in my clinic. So aspirin, warfarin, this is directly in the FDA prescribing information. If you haven't gone to the FDA, looked at the Lexapro label, I highly recommend that you do. Lexapro affects platelet function. Adding anything else that affects clotting increases the bleeding risk. So this includes over-the-counter ibuprofen and aspirin, not just prescription blood thinners like warfarin. And then MAO inhibitors. MAO inhibitors are contradiction with Lexapro. A minimum 14-day washout period is required before starting escitalopram and stopping an MAOI. Combining them can cause serious or life-threatening serotonin syndrome. And this is not a theoretical risk. This is real life. You've got to be careful there. And then, of course, other serotonin-generic drugs that you want to take a look at, serotoninogenic, are triptans, tramadol, lithium, buspirone, amphetamines, and those all increase serotonin risk syndrome when combined with Lexapro. All right, let's talk about the herbs that you should discuss with your provider before taking Lexapro. This is the herb caution table now, and I want to kind of go through each one of them briefly. But before I do, I want to say something important. Herbal medicine is powerful. That is exactly why it deserves the same careful consideration as prescription medications when it comes to interactions. Just because something is natural does not mean it is neutral when you are also taking a prescription. St. John's wort, this is the most important one. St. John's wort is listed directly in the FDA prescribing information as a known serotonin syndrome risk with Lexapro. And this is a hard do not combine, do not go there. It is not a proceed with caution. You do not use those two together. So kava may affect the liver enzymes that actually break down Lexapro, potentially changing how much medication stays in the system. Kava also has its own independent liver safety concerns, regardless of other medications being taken. And both of those things are true at the same time. So it can affect liver enzymes that break down Lexapro, and it could just affect the liver on its own without medications. Black cohosh, this one's also popular in my population. And it's especially relevant in my audience because it is commonly used for perimenopausal and hormonal symptoms. Another herb that I will work with in my own clinic. Lab studies show it may affect CYP2D6, CYP2C19, and CYP3A4. And through clinical trials, the results are actually mixed. So the honest answer for this one is that evidence is not fully settled, but disclosing use to a provider is the right call. Talk about this herb if you want to take it while you're on Lexapro. Don't just jump into it. Ginkgo biloba. So ginkgo has blood thinning properties of its own. Because Lexapro already increases bleeding risk, combining the two may compound that effect. And this is more relevant for anyone also using NSAIDs or aspirin. Ginseng and milk are both worth those or disclose those to your prescriber. Ginseng has a low interaction risk in most clinical trials, but some research suggests possible CYP3A effects at higher doses. Milk thistle shows possible enzyme effects in lab studies, but human trials have generally shown little significant interaction. The pattern here is always tell your prescriber if you're taking herbs or considering herbs, or tell them about anything that you're taking. So let's talk about supportive strategies. I want to say up front that these are not replacements for the medication, they are context for medication. The goal is to support the foundation the medication is working on. Folate status, given everything we just covered in the lecture, especially the paradox section, folate status is worth knowing. L-methylfolate is the active form that crosses the blood-brain barrier. For people with MTHFR variants, standard folic acid may not convert efficiently into the form the brain can actually use, so testing before supplementing is always preferred over guessing here. Vitamin D. So over half of SSRI users in the NHANES study had inadequate vitamin D intake. Vitamin D supports mood, immune function, and bone health. So sunlight and dietary sources are preferred first. And then testing tells you where you actually stand and if you need a supplement. Zinc. Zinc combined with SSRI use was specifically linked to lower bone density in the NHANES data. Zinc also played a role in neurotransmitter function and is commonly deficient nutrient in the neurodivergent population. So we see this running low when we're looking at lab work for zinc. Omega-3 fatty acids, whole food sources like fatty fish and eggs are preferred first. Omega-3 support neurological and mood function and are broadly supportive for the nervous system. And sleep consistency. Start here. Consistent sleep and wake timing support serotonin regulation. Insomnia is one of those most common side effects of Lexapro. So addressing sleep hygiene is clinically relevant and not just lifestyle advice. It should be part of the protocol. Sodium monitoring, particularly relevant for women, older adults, and anyone on diuretics. Electrolyte monitoring. Antidepressant treatment is clinically reasonable, giving the documented hyponatremia risk to Lexapro. So get those electrolytes checked. So let me close with this. Lexapro is not inherently good or bad. It is powerful, and powerful tools work best when the foundation is solid. If you're on Lexapro and not feeling the way you expected, or if you are experiencing side effects that were never explained to you, the answer may not be a higher dose or a different medication. It may be what is happening in the body underneath the prescription. Understanding what your body needs alongside this medication is not about fear, it is about informed care. Thank you for being here. I would love to know if anything in this presentation was new information for you or if you have questions. You can find me at botanicalhealthclinic.com. Just shoot me a message to the website. And if you would like a copy of the slides, just email me there as well, and I'll be happy to share them. Thank you so much.